and it made for minimal friction in the community with the patients, and I think considerably few problems really for both the plan and the state.
When you think that the key to a good functioning program is the physician acceptance? One of the keys?
Very definitely. Particularly when you...
The program is conversation, unrehearsed, spontaneous, featuring people from different backgrounds and walks of life. Appearing on tonight's program are Gregory Washington, James Schubert, and Dwight Gedoldig.
In one facility where the physician comes to the patient, and which is a little different from the situation where the patient goes to the facility, goes to the physician. So today our problems aren't as great as they could be if we had a decentralized situation, which we are anticipating.
I think we ought to share with our viewers our conversation, and we're talking about prepaid health plans, which is not a new way to deliver health care, but it is an innovative way to deliver health care in the sense that we are embarking as a government program on a new and a different way to deliver health care to the poor of California. That is, those people who are involved with the cash grant, the welfare group in California, of which there are about 2.5 million people. And as a government official, we are concerned with getting quality care to the poor, and there has been some dislocation and some dissatisfaction with the current program. And the Department of Health Care Services and the Reagan administration embarked on a capitation plan approach to delivering health care about 16 months ago. Basically, I think both of you will agree that a prepaid health plan is merely a way to furnish health care to the poor or to any other group of people on a fixed fee basis, whereby the person gets all of his or her health care from a particular plan, and that health care is paid for at a monthly flat fee. We have with us two different modes of delivering health care. Greg Washington with a so-called closed panel plan in which a clinic-based operation is involved, and the prepaid plan operates to the extent that the patient gets his health care through the clinic and is referred to specialists. And Dr. Schubert, who is president of the Sacramento Foundation, Medical Care Foundation, has another approach to it, and that is where the physician treats the patients on a fee for individual service basis and bills the plan, and the plan in turn receives a flat fee for the number of patients that are in the plan. I think that, Dr. Schubert, I'd like to have you share with us how you feel about prepaid health plans, particularly with California's poor, and how successful you've been.
Well, I think that the prepaid program, as you mentioned, afforded many of us the opportunity to get some private industry input, if that's a good term, into the management of a government program. And for years, the medical societies and associations have been complaining about some of the inequities in the various governmental programs, and now we have an opportunity to take over management and manage a program for a vast number of people. As you know, because of fiscal problems that developed over years because of certain problems within the welfare budgeting and so forth, there were certain restrictions placed on utilization of the program. And this was a wonderful opportunity to demonstrate that private physicians and medical associations in the form of a foundation could manage a large health program and do it within a fixed budget.
Your program started last summer, is that correct?
That's right, yes.
And you are furnishing health care to how many people now?
Well, we currently have enrolled 40,000 people.
And where?
In Sacramento and 4 surrounding counties, Sacramento, Yolo, Placer, Nevada, and El Dorado. We have 850 privately practicing physicians, and including physicians at the university hospital, physicians in group practices and so forth, who are all participants in this program. In addition to that, we have agreements and membership agreements with 24 of the hospitals in the area.
Does that include the Sacramento Medical Center, the teaching hospital?
Yes, we do have an agreement with the medical center, and they are participating in the program.
I see.
Not exactly on the same basis as some of the other hospitals because of some of the governmental, regulations and so forth, but participating.
I see. Also, Greg, I think that you're delivering health care in a slightly different mode in Los Angeles in a minority area. And your plan is one of the older plans in Los Angeles in a prepaid mode in which the physicians are pretty much grouped in a clinic except for the specialty groups who are on a referral basis, I believe.
That's correct.
Yeah. And can you tell us about how your plan is working?
Our plan is, we're quite excited about the results we've been able to attain, particularly when we look back at some of our original planning that was done as long ago as 3 years ago. The factors that we're particularly impressed with is that we are able to deliver a better quality package for the patient, in that the patient can actually receive the services that are indicated and not necessarily the services that allow a physician to be paid for the services that he has to render. Many of our viewers may not realize, but the insurance industry has established a system that essentially reimburses a physician on the basis of what's logical to an insurance claims examiner. There are many services that are unique to the Central LA area that have to do primarily with education. It covers such problems as communicating not only in the doctor's office, but communicating in the home. Our outreach system, I think, is an outstanding example of an approach that we've been able to utilize in this prepaid mode. Prepayment as a concept sometimes comes over as a very difficult concept, but I think if many of the viewers may have private insurance companies and have ID cards that identify them with those companies. And prepayment to me is really no more than a monthly insurance premium that we as a health plan receive. And the only distinguishing characteristic between our program, which is an insurance program or a comprehensive health scheme, and a major insurance company, is that our services are more comprehensive, and the flexibility that the physician and the paramedics are provided with allow them to address some of the things that we're doing, like in our outreach program. In outreach, in a nutshell, we have a team of nurses, RNs, LVNs, that go to the doctor's home, go to the patient's home as an extension of the doctor's office, and not only assist the physician in solving some of the problems that occur within the homes that are, contributing factors to poor health problems, but actually spot some of the problems that right in the bud that are going to perhaps show themselves months or years later.
Well, in effect, you've got a sort of a preventive medicine program in effect, haven't you?
Exactly. Our clinic was established 5 years ago by Dr. Bassett H.L. Brown, the medical director and founder, and Dr. Woodard, his partner, with the sole intention of providing preventative medicine techniques in a community that was really in a health crisis. So many of the facilities and so much of the attention had concentrated on stopping the problem or curing the problem after a disease or an infection or a health situation had become catastrophic. So our program is preventative in the truest sense. We do such things and have done such things before the prepaid program as send out postcards on our computer system to notify children, as an example, when it's time to come in for immunization schedules and growth examinations and routine health examinations. We've broken our patient base up into primary sectors, and there's a different treatment regimen for each one of those sectors. And we have a very high utilization in the doctor's office, but we do believe that this is going to be the primary reason that our cost in some of the high-cost centers, such as the hospitals, will be significantly reduced.
I see. We mentioned health maintenance. Dr. Schubert, that is a very popular term in the Congress these days, and I understand that the administration is going to the Congress again this year and seeking funds for an HMO bill. Would you like to talk about what you think HMOs are and how they relate to the foundation plan?
Well, health maintenance organizations, or HMOs, are organized methods of taking care of people and organized methods of financing care. And there are different models that can be done. I think the classic model is the Kaiser type of model that we're very familiar with here in California, where an organization such as Kaiser hires or has a hospital and has under contract physicians who take care of people who register in their health plan. And the people who register in their health plan, either individually or through employment or some other group, pay a certain amount of money, and the program guarantees to take care of them for the things which are covered under the contract. The other types of models are those which are built around, let's say, a cluster of neighborhood clinics or a cluster of hospitals, and other types are such as we have, the foundations, in which each doctor and each hospital retain their own identity, but they group together administratively through cooperative agreements and attempt to organize the way that medical care is practiced and delivered. We think that the maintenance of health obviously has been very important, and it's nothing new. Health maintenance is right now is a political term, but medicine has been involved in maintaining health for ever since its existence. I mean, that's why medicine is that we're accused of being crisis-oriented, but if you look at the massive strides that have been made in medicine through the research laboratories and elsewhere, such as an example is polio, a classical example. And doctors have not been withholding techniques to preserve good health. It's not that at all. But what we're talking about is similar to what Greg has talked about, is that let's be sure that the people who are in the program are getting the advantages of all the things that we know scientifically. So that if you have a group of youngsters in your program and you know that they should be receiving their immunizations at a certain periodic time, if they have not come for their immunizations, then the program should bring them in. Now, if they don't want to come in after you've contacted them, that's another problem. That's an educational problem. And that does relate to the way medicine is practiced in some areas, and it's a very important thing. Health maintenance means attempting to maintain good health by early and periodic examination, detection, and ways of preventing certain diseases. Now, we've had some very interesting discussions over the past few months with people who are very knowledgeable in the financing of medicine, and there is some very serious doubts whether health maintenance in the long run will not simply increase the cost to the American public, and probably will. For a lot of reasons, one of which, if you find disease early, you're going to treat it early. And this means your costs start sooner. And some diseases are not curable. They are, you can prevent some, but you can't cure some. And an example might be some types of cancer. Well, you may be able to detect a cancer early and cure it, and other cancers are not curable, but by picking them up early, you make the patient more comfortable and prolong their life. This prolonging their life will not reduce your cost, but will make for a better person, obviously, and a happier person for the time that they have. So there's a lot of discussion and considerations on what an HMO will do in the long run. We do know that it is one type of response to organizing the taking care of sick people and trying to prevent people from getting sick.
Are you, in your own mind, convinced that preventive medicine is the way to go, question one? And question two, what is specifically the Sacramento Foundation or your family community plan doing? And I would ask Greg the same question. Aside from the outreach, what formal moves are being made to get into this preventive medicine mode?
Well, we have had, and since the beginning of the program, a good communication system between the foundation and the patients or the enrollees, the members of the program. We have newsletters which come out at least once a month. To the patients, and most of the newsletters are on the topic of health maintenance, how to guard against certain types of illnesses and what to do in case of certain things, and how to receive care early. Our recent newsletter is a pediatric problem concerning keeping your drugs under lock and key so your kids can't get at them at the wrong time. And
I noticed some of the new medicines are coming out with this kind of a cap that you have to press down so the kids can't get it open.
Yeah, but kids get smarter than druggists sometimes.
Very good. Our program is utilizing a technique that I guess we're really all familiar with, and that's education. I think and we feel that the most important contributing factor to maybe keeping that spiraling cost in check is going to be through the types of education Dr. Schubert has suggested. We're doing such things as we have people in our lobbies that are showing films on health care, the reasoning for having a pap smear, the reasoning for the immunization schedules. The outreach system that I'd referred to has a very definite education responsibility. We have an internal computer system which allows us to categorize patients and send specific information out to specific areas of disease, similar to Dr. Schubert's newsletters, health tips, summaries of medical problems in layman terminology. And we recognize that in our particular community, the biggest problem is pure communications. Just saying the facts and printing the information is really not enough. We do such things as customize the diet plans, as an example, for hypertensives, so that the foods that are called for within those diets are foods that the people, in fact, can relate to and can purchase.
Does that eliminate soul food, Greg?
Well, it doesn't eliminate soul food. I guess it kind of acclimates soul food so that it can better suit the diets. It's a very good question because I
know people get caught up in those kinds of fads.
Exactly. Well, the biggest oversight in American medicine today is the failure to realize that it's one thing to suggest a course or a diet for a patient, and it's another thing to have that patient, in fact, follow that diet. So we have to really deal with the realities of the ethnic eating habits, and we, frankly, are faced with 3 or 4 different ethnic groups that have 3 and 4 different ethnic eating habits. But essentially, it's economics. And if you can tailor a diet that where you can purchase the foods, then, in fact, you can do something for the patient and have him working for you, a partner in his care. But the key thing here is that to realize that diet is a very important component of better health and preventative health.
You know, I think that the thing that separates the foundation program and Greg's, 2 of ours, from the ordinary type of insurance program, which we referred to earlier, I think you can imagine a prepaid program as simply buying insurance for a group of people who are of low income. That would be a simple way of explaining it. But as Greg indicated, and as we have found through our experiences over the past 9 months, that it's not that at all. It's taking care of people, and we're getting into their personal problems and having a way of helping them solve their problems. And it's the problems that have come through the foundation from person-to-person contact, solving doctor-patient problems, not in the point of rapport, but problems which neither one know how to approach. And we, I think on the second day of our operation, we had a full-blown patient services bureau. Now, you might think of it as a complaint department, but it's really not. It's a service bureau, and we have it staffed by highly skilled professional people, RNs similar to Greg's, and they go out after personal problems. We can't solve all the problems, but it's the first time that I know of where organized medicine, in the sense of the traditional sense, has gone and attacked on a working operational level rather than a theoretical level the problems relating to how people live in our community. This is not only in the ghetto, which we have people, but people in other parts of town and county, and some in the foothills and the mountains, and each one is different. It's really an amazing thing.
So you have an outreach program going too?
We have an outreach program too, sure, and we also have a 16-passenger bus in which we use to transfer people around to make their appointments, make sure they get to the doctor on time, they get to the laboratory and get their tests done. It's an experimental thing, but we think it's an extension of good medical care, really.
Greg, have you got a bus line running also?
Oh, we certainly do. We have a complete network for transportation that we provide. And I might add that some of these features, special features such as transportation, such as education, we have a nurse that is assigned to the hospital to take care of patients on our staff, primarily just in the communications problems, being sure that the patient understands the doctor's instructions. These special features cannot be billed or paid for in the conventional way of purchasing health care by the private consumer or by the government. And it's these enhancements and these improvements in the delivery of health care that complement the preventative medicine theme, at the same time give you a much better level of service to the patient. So that in itself is going to solve some of the cost problems and some of the problems and just loss of patients' capacities, of their capacities and of health.
You two are both strong proponents of prepaid health plans for different reasons, philosophically. I'd like to share with our viewers how the administration, the state government, feels about prepaid health. And we feel that the delivery of health care through a fixed fee, the prepaid health approach, is a viable way to do it. I think that it is fair to say that we agree that it is not the only way to do it, that the traditional fee for the individual service rendered by the physician is also a good way to deliver health care and will continue. This administration is most anxious to see the prepaid plan concept spread throughout the state of California. In the United States today, there are 45 HMOs or prepaid health plans, if you will. 25 of them are in California. The oldest one, of course, is Kaiser, which is about 30 years old. Currently, we have about 140,000 Medi-Cal patients under prepaid contract, including Dr. Schubert's and Greg Washington's plans. And they have a potential total enrollment of somewhere in the neighborhood of 600,000 people. We currently have in the Department of Healthcare Services 48 proposals which will cover an additional 1 million people. And we are most anxious to see that this concept is undertaken by the medical professionals and that responsibility is transferred to local health care. Recently, Jim and I were talking about the possibility of national health insurance. And I've been in Washington a number of times recently, and I know that Dr. Schubert has. And all I hear back there is that national health insurance is coming in 1976. And we feel that what is happening in California, and I'm sure that Dr. Schubert shares philosophically that concern with me, is what is going to happen in national health care if we can show the way to go. And I'm curious now to find out what each of you feels about the prediction of the prepaid mode and how that is going to go in California. Aside from the Medi-Cal program, just as a healthcare delivery system. Dr. Schubert?
Why me first?
I'll take that on.
All right.
There's a couple of significant factors that I think one has to keep in mind. One is that health is becoming a right and not a privilege, and that we have conservative administrations both at a national level as well as a statewide level. I think that is going to only modify the delivery system in this way, and that will be that the consumers or the people buying the health delivery systems or health packages may be employees. Now, there's a lot of debate about the Kennedy plan and about socialized medicine, but I think essentially all Americans will be eventually covered by some comprehensive health care package. And that comprehensive health care package will be bought by state governments, county governments, city governments, and of course the private sector, the employers such as the large companies. And Personally, it's my feeling that the rest is really left up to speculation. Now, of course, Dr. Schubert may have a different cut on that. Like, I'd be very interested in hearing his opinion.
Well, I think that there will be some form of national health insurance by 1976. I feel very strongly, and certainly it looks like it from everything that comes out of Washington and in private conversations elsewhere. It looks that there will be some type of national health insurance financing scheme. I think the biggest problems in medicine, one is financing. That will be or may not be resolved by some form of national health insurance. But to get to what I think about national health insurance peripherally, I like to say that the major problems facing the profession of medicine right now is, one is the distribution of physicians and the production of surgeons and other specialists in the postgraduate training programs. I think that if we are to retain some autonomy within the profession, that the organized medicine in the form of American Medical Association, our California Association, and any other of our specialty organizations, such as orthopedic surgery as myself, and all the associations aligned with medicine should have some way of regulating the production of physicians so that we get more family doctors and primary physicians into practice. I don't think that you can have a national scheme of prepaid medicine, as you're talking about now, without having a tremendous turnaround in the number of family physicians that are being produced, because I don't think you have enough primary physicians. I think that you would run into a very quick, abrupt end into the development of this mechanism of health care. So I think that national health insurance, from a practical point of view, will not be based entirely on prepayment. It will be based on a mechanism of financing either through the government and administered by the government or through a system similar to Medicare, probably. However, I think that the options will be there for a group or a person to join a group type of practice, either a closed panel practice such as Greg's or an open panel type such as the Foundation, in which they can have some freedom of movement, either from one sector to the other sector, or say 3 different choices. A system of indemnity, perhaps, or a system of service corporations, or a system of closed panels. So I think there'll be some options. It was interesting to note that in reading Senator Kennedy's bill just this past week, one that was just introduced, that he has made some major revisions in it, one of which affects the foundations. Now, the foundations are supposedly defenders of the fee-for-service world, and if we are, then we accept that challenge, but...
May I interrupt and ask you to explain to the viewers what a foundation is?
Okay, a foundation is an organization formed by a local county medical society that operates independently. It's nonprofit, has its own board of directors, usually mainly physicians, but other health professionals such as hospital administrators. We have public members on the board. It's a voluntary organization in which the doctors in the community voluntarily join. They agree to practice in a group environment in that they maintain their own offices, but they agree to collectively participate in certain programs. They have agreed to maximum fee reimbursement schedules. We agree to certain administrative procedures and the like. We have certain model programs which we follow, and this is the way the doctors practice. It retains their ability to work independently. They're not on salary. If they work hard, they make...
This has been Conversation, unrehearsed, spontaneous, featuring people from different backgrounds and walks of life. The opinions expressed on this program are not necessarily those of KXTV-10 or of its management. Conversation, a pre-recorded public affairs presentation of KXTV-10.
Unless you're in a group practice, you could not be